that H3N2 is the most common subtype. Otherwise, we have human influenza H1N1, avian influenza H5N1. China first time reported H7N9 in 2013, and recently they have reported China again H10N3 for the first time. Now, type B is second most common, and type C is currently not circulating on this planet. When we look at whether it is swine flu or bird flu, the drug of choice is oseltamivir. Tamiflu. For cases, it is 75 mg BD into 5 days. For chemoprophylaxis, it is 75 mg OD into 10 days. We are talking of Tamiflu or oseltamivir as a drug of choice, both for cases as well as chemoprophylaxis. Vaccine available live and killed form. Killed vaccine, when we look for influenza, it has a strain A7 California 2009 strain. This is, can you make a diagnosis? Yes, we are talking of the disease diphtheria. Pertussis is whooping cough or 100-day cough. But when you look at diphtheria, causative organism is Corynebacterium diphtheriae. Now, how we have diagnosed using the first image that this is Corynebacterium diphtheriae? Yes, green colored bacilli. So, definitely this is Albert strain. We can use Neisser Ponder strain also. And these bacilli have a typical, you can see, arrangement known as Chinese letter or cuneiform arrangement of bacilli. L form, V form, X form. At the same time, each bacillus at the end, you can see we have volutin granules, also known as Babe-Uns granules, polymetaphosphate granules, and metachromatic granules. Now, vaccine TD, I told you, has been introduced in the National Immunization Schedule of India. Instead of tetanus toxoid, which we were giving at 10 years, 16 years, and in pregnant females, TD has now been introduced as a replacement at these 3 times in the program. Diphtheria, the immunity status test is Schick test, where we used to take reading after 96 hours. Now it has been replaced with heme agglutination inhibition test. We have already discussed Mycobacterium tuberculosis, acid fast bacilli, red colored, Ziehl-Neelsen stain, beaded appearance, mycolic acid. They are mostly single in nature. Anti-tuberculosis day is observed on 24th of March. Location of National Tuberculosis Institute is Bangalore, and Tuberculosis Research Center is Chennai. Barometer of social welfare is tuberculosis, where one case give rise to 10 to 15 cases per year. In contrast, lepra bacilli, although they are also red colored acid fast bacilli, but they are in groups or clumps known as globi, and they are non-beaded. On the left side is, yes, easiest to identify, COVID-19. COVID-19, when we look, this was earlier reported as pneumonia of unknown etiology on 31st December 2019 by Chinese authority from Wuhan city, Hubei province, China. Then it came to or spread to other countries of the world slowly and became a global pandemic. March in India, it was reported for the first time from Thrissur district of Kerala. Now, when we started COVID vaccine immunization with Covaxin and Covishield in our country, the first dose was on 16th of January 2021. We were able to achieve 100 crore doses milestone same year on 21st October 2021 and subsequently on 17th July next year, we achieve the milestone of 200 crore dose of vaccination in the country. On the right side, the image, can you make a diagnosis by looking at this image? Yes, it is mucormycosis, common language known as black fungus. But how do we identify this is mucormycosis by the pathological appearance? It is due to ribbon-like hyphae. And if you see carefully, they branch at 90 degree. If you do a radiological investigation, as Dr. Zainab Vora ma'am will tell you, you will find black terminate sign on MRI and you will find bony erosions and mucosal thickening on CT scan. If you see, its drug of choice in India has been LAMP, liposomal amphotericin B, just like we have in Kala Azar or visceral leishmaniasis in the country. Let's move further. This is, yes, nasopharyngeal swab used for diagnosis of many important infections in the country like swine flu, like COVID-19. And what is shown in this particular image is the, yes, RT-PCR test. RT-PCR test also has been the diagnostic test of choice for many diseases like swine flu and COVID-19 in our country. Look at this particular image carefully. What does this show? Look carefully. We are looking at RNA to cDNA, then amplification and detection. So this is actually the process of RT-PCR, which we were saying is the diagnostic test of choice. Hepatitis B serum markers. We have three types of antigens and there are three types of antibodies. What is the sequence of appearance of antigens? First to appear is hepatitis B surface antigen, then comes core antigen, but it is very rare to be seen, and last is hepatitis B envelope antigen. But their antibodies do not appear in the same level. First to appear is anti-HBC, then anti-HBE, and last antibody is anti-HBS. What is epidemiological marker of hepatitis B? That is surface antigen. And also Australia antigen is the name given to surface antigen. What is marker of infectivity in hepatitis B is envelope antigen. Now you tell me why envelope antigen is marker of infectivity? Because it indicates active viral replication. But what is the marker of acute hepatitis B? That is anti-HBC. Of course, logically, when we are looking at acute disease, we are talking of IgM, right? If it is IgG, that would be a marker of chronic hepatitis B. Anti-HBE, if it appears, that means active viral replication has stopped. This is marker of good prognosis. And anti-HBS is marker of end of period of communicability. When we test vaccinated individuals, we are likely to see anti-HBS. Can you make a clinical diagnosis based on this particular diagram? In fact, you can see they have mentioned also step ladder fever. Fever is increasing in steps, 0.5 degree, 0.5 degree, 0.5 degree slowly. This clinical diagnosis is typhoid, enteric fever caused by Salmonella typhi. Now, besides stepladder fever, patient may have rose spots, coated tongue, and a characteristic appearance of stools, that is pea soup stools. So, rice watery stools in cholera, Vibrio cholerae, darting motility, hanging drop preparation is the field diagnosis of cholera. But in typhoid, diagnosis is based according to the timing of the illness. So, for diagnosis we use for this fecoral disease pneumonic basu. Blood culture first week of illness onwards. Antibodies Vidal test second week onwards. Stool culture third week onwards, and fourth week onwards is urine culture. But overall there is no doubt blood culture is the best test for diagnosis of typhoid. For typhoid, the drug of choice is third generation cephalosporin ceftriaxone. Otherwise, ofloxacin is also used as a treatment modality. Two important vaccines. One is live attenuated, TIFE oral. This live attenuated vaccine TIFE oral is taken 3 times on day 1, 3 and 5. Also we have Typhim VI. Typhim VI, which is intramuscular, has a VI polysaccharide also. Health education is the best measure for prevention and control of cholera typhoid epidemics. Now, when we look at diarrheal diseases, most common in India has been the cause of fecal transmission is rotavirus, but otherwise typhoid, cholera, hepatitis A, hepatitis C. A is overall commonest in children of India. E is commonest in pregnancy and the highest or most common reason responsible for mortality in pregnancy. All of them we use different management methods, but overall the management of choice more than the drugs, it is oral rehydration solution. So currently we are using WHO reduced osmolarity ORS. This WHO reduced osmolarity ORS has 4 major components. These are sodium chloride, potassium chloride, sodium citrate and glucose. When we look at their weight wise composition in a single packet of ORS, sodium chloride is 2.6 grams, potassium chloride 1.5, sodium citrate 2.9, glucose 13.5, giving a total of 20.5 grams per 1 ORS packet. It should be dissolved in 1 liter of water and it should be consumed within 24 hours. ORS, which was originally developed by Dilip Mahalanobis. When you look at its osmolar concentration, sodium ions are 75 millimoles per liter. Potassium ions are 20. Chloride ions are 65. Citrate is 10. Glucose is 75. Giving a total of 245 millimoles per liter of ORS packet. If you look at Rizomel, Rizomel is actually rehydration solution for malnourished. This is an ORS where sodium is halved to 45 millimoles per liter and potassium is doubled to 40 millimoles per liter. Also we use super ORS where instead of glucose we use rice or alanine based sugar in the ORS. So these are different types of ORSs which are asked in our examinations. When we look at worm infestation, most common in India has been roundworm. feco-oral route of transmission, Ascariasis, it is known as Ascaris lumbricoides is the causative agent, and its drug of choice is albendazole. Most common because 70% population is affected with that, but generally we don't face any problem. A worm which has been eliminated is guinea worm from India. Guinea worm, Dracunculus medinensis is the causative agent. Drug of choice niridazole, and it was eliminated from India February 2000. One of the major actions which resulted in its elimination was banning of stepwells in the country. So stepwells were banned and it resulted in elimination. Third type of worm is shown on your screen right now, that is hookworm. Two types, Ankylostoma duodenale, resident of duodenum, and Nicator americanus. How does it reach human beings? Whereas round worms were fecal. Guinea worm dracunculiasis was consumption of water containing cyclops infected with guinea worm embryos. Hookworm is penetration of skin of foot. Larva migrans you can see in the image. Hookworm problem you can assess by an endemic index known as Chandler's index. This is number of eggs of hookworm per gram of stool of community, not individual person, you cannot monitor treatment, per gram of stool of community measured by Kattegat's technique. If Chandler index is more than 300, it indicates a major public health problem. Drug of choice albendazole, and hookworm problem is associated with hypoalbuminemia and iron deficiency anemia. 0.03 to 0.2 ml blood loss is there per worm per day. Please remember the fourth type of worms are tapeworms. Taenia solium, where pigs, and Taenia saginata, where cattle are there, right? There we use drugs like praziquantel niclosamide. Albendazole can be used for neurocysticercosis. In both these worm infestation, solium and saginata taeniasis, man is the primary or the definitive host. After having seen these worm infestations, we come to arboviral infections. Friends, when we look at arboviral infections, they are broadly divided into three groups. Arboviral means arthropod borne viral infections. So we have group A, where Sindbis and chikungunya fever is there. Group B include majority of important infections. So dengue, West Nile fever, yellow fever, all these will be included in group B, and others will include Chandipura virus, Ganjam, Meenal, Dhori viruses. Now on your screen, this disease, make a clinical diagnosis. Yes, this is a dengue infection, commonly known as, yes, break-bone fever, characterized by retroorbital pain and thrombocytopenia. Platelet count becomes low. What is exactly shown in the image is actually the clinical bedside dengue diagnosis, and this test is known as tourniquet test, known as Hess test in medicine, and capillary fragility test in pathology. When we look at this tourniquet test, we tie a BPF cuff, raise the BP above systolic, wait for 45 seconds to 1 minute. Because of thrombocytopenia, petechial spots will appear in cubital fossa. In cubital fossa 1 square inch, you have to count the number of petechial spots. If there are more than 10 such spots per square inch of skin, diagnosis of dengue fever could be made directly. And if these petechial spots are more than 20, dengue hemorrhagic fever diagnosis. If additional features of shock are present, then dengue shock syndrome diagnosis could be confirmed. Dengue vector is tiger mosquito, Aedes aegypti, and it is covered under the program National Vector-Borne Disease Control Program of India. Chikungunya also has fever, but that has typically doubling up appearance, painful movement of joints along with hyperpigmentation. It also has Aedes as the vector. It also has thrombocytopenia. It also has tunicatase positive. But reservoir of chikungunya is primates or the monkeys. This is, yes, we are talking of the most common vector-borne disease of India, malaria. Now there is a small difference. Technically, you should read carefully in the paper. When I say most common vector-borne disease, that is dengue. But when I say most common viral vector-borne disease or arboviral vector-borne disease, that is dengue. So coming to malaria, causative agent is Plasmodium, 4 species, Vivax, Falciparum, Malariae and Ovale. All 4 are seen in India. Most common is Falciparum. It is most common cause of complications and only cause of death also. It has the shortest incubation period of median 12 days. Also, when you look at Falciparum and Malariae, both of them have no relapse. Because in Falciparum there is no exoerythrocytic phase, hypnozoites, but its infective form is sporozoite. Trophozoite is the infective form in blood-borne malaria and congenital malaria. Diagnosis classically is done by peripheral blood smear, where we make 2 types of smears. The thick smear on the left side of the same slide and thin smear on the right side of the same slide. So one slide, 2 smears both on the same side, and we use staining procedure JSV. Jaswant Singh Bhattacharya stain. Thick smear is for confirming the presence of Plasmodium or malaria. So it is a sensitive test. Thin smear tells you species also. So this provides specificity to the test. Now we also have dipstick test for diagnosis. Dipstick test is based on a particular antigen, that is histidine rich protein type 2 Plasmodium falciparum antigen for diagnosis of malaria in the country. Vector is female Anopheles. How will you identify Anopheles? It sits at 45 degree to the surface of skin while taking a bite. Its wings are spotted on the margins, black spots on margins of wings. And when we look at its larva rest parallel to water surface because it has no siphon tube and it has boat shaped eggs with lateral floaters. Anopheles has more than 55 species, but when we look at rural malaria, then Anopheles culicifacis is the vector. Urban malaria, Anopheles stephensii is the vector. Larval control is the best measure for prevention of malaria when larvae are present, otherwise source reduction is. Anopheles is also known as sophisticated mosquito because it requires clean water for breeding. This is disease rabies. What is shown in the first image is pathognomic clinical feature, that is hydrophobia. Aerophobia is also present. What is shown in the third image is pathognomic microscopic feature, that is negri bodies, mainly found in hippocampal area. In between second image is bullet shaped rhabdovirus family, and this particular rabies is due to Lissa virus 1. Rabies could be transmitted due to bite of any mammal except man and rat. So dog, cat and other mammal bite, scratches also. If you look at rabies vaccine and immunoglobulin that we have discussed, what we should know is wound management will require soap and water for 15 to 20 minutes. Ideally, no suture. If it has to be there, then 1 to 2 loose sutures with local antiserum cover. Use locally available antiseptics. Vaccine to be used, immunoglobulin to be used in only category 3. Immunoglobulin not to be used after 7 days of starting the vaccine. Epidemiologically, rabies free regions are waterlogged bodies, that is islands. So Andaman Nicobar, Lakshadweep in India, otherwise China, Taiwan, Japan, Cyprus, all Australia, all are rabies free. When we look at specimens for diagnosis of rabies, we have biopsy of skin follicles on nape of neck, posterior margin of neck as the ideal specimen in a living person. If not possible, then corneal smears could be taken. Dead persons or dogs, we take hippocampal brain biopsy for diagnosis. Yellow fever, also known as American plague, another arboviral disease where the route of transmission is vector, Aedes aegypti. This disease does not occur in India due to cross immunity or cross tolerance provided by high circulating level of dengue antibodies in Indian population. When we look at particularly yellow fever vaccine, it has strain 17D, Dakar antigen units, a type of live attenuated lyophilized vaccine, which is reconstituted with cold physiological saline. This vaccine, when we look for international travelers health emporiatric science, the validity of vaccination certificate is 10 days till lifelong. The disease has an incubation period of 2 to 6 days, where 6 days is taken because it is maximum incubation period as the period of quarantine. Quarantine 40-day detention concept was first applied for plague, sea sailors. The vaccine requires a cold chain temperature of -30 to +5 degrees centigrade for maintenance. This is life cycle of Japanese encephalitis virus, another arboviral disease. Now, when we look at JE, it's caused by Japanese encephalitis virus, but its vector is Culex tritineorhynchus. Culex vishnui and Gelidus are also its vectors. It is basically a life cycle between ardite birds, water birds, who act as actual host of this disease. Ducks, fowls, herons. Pigs act as amplifier host. Organism multiplies. Cattle and horses act as mosquito attractants. And what is the role of man? Man is a accidental host for this disease. This disease requires water to be present throughout the year at a place like rice paddy fields. So disease is prevalent throughout the east and southern India where rice cultivation is done. Present in 70% of our country. So we have live attenuated vaccine lyophilized, phosphate buffer salined vaccine, where SA14-14-2 is the strain and it is given in 2 doses, 9 months, 16 to 24 months. This disease is most commonly seen in age group 1 to 15 years of age and it has two major foci in the country. One is Gorakhpur in East UP and now West Bengal also. What is rough eye? We are talking of the disease trachoma. Now, trachoma is a disease of low infectivity. Having an incubation period of 5 to 12 days, it is caused by Chlamydia trachomatis. Now, when we look at field diagnosis, mostly this is a fomite-borne disease which can spread through housefly also. When we look at clinical field diagnosis, 2 out of 4 of these conditions should be present. 5 or more large follicles on upper tarsal conjunctiva, Herbert pits, these are limbal follicles, then scarring, and fourth is pannus formation. Any 2 out of these 4 field diagnosis is confirmed. For trachoma, the drug of choice in India is azithromycin, single oral dose, 20 mg per kg stat. Prevention and control strategy, safe strategy which is shown in the image. S is surgery. This surgery is allowed for 2 conditions. These are trichiasis and entropion. Then antibiotics, that is azithromycin. Then facial cleanliness and environmental hygiene or improvement. So surgery, antibiotic, facial cleanliness wash, environmental modification, trachoma control in the country. Current status of India. India has been declared trachoma free. 2017 onwards by WHO. This is, make a diagnosis friends. Yes, this is leprosy. One of the oldest disease known to mankind beyond anthrax. Leprosy bacilli was discovered by Hansen of Norway. So this is also known as Hansen's disease. This is modified ZN stain we use to identify red colored acid fast bacilli which are not single like tuberculosis. They are in groups known as clumps or globi. Leprosy was declared eliminated in India in December 2005 because India achieved its elimination level. Elimination level of leprosy across the world which India achieved in 2005 is less than 1 case per 10,000 population, and this is the prevalence rate. Incidence is known as ANCDR, annual new case detection rate for leprosy. First sensation lost is cold temperature loss. You can easily identify this is very right, HIV virus. So we are looking at HIV AIDS as a disease. Now when we look at this, carefully remember first case in world, first case in India. World it was 1981 USA. First case in India was 1986 Chennai, Tamil Nadu. But if you are asked first virus discovery, that was in 1983, where HIV-1 was discovered, and in 1986 HIV-2 was discovered. When we look at India, HIV virus 1C is the commonest subtype. This HIV virus discovery was done by Robert Gallo in USA and Montagnier Sinossi in France. But when we look at Nobel Prize for discovery of HIV virus, that was given to Montagnier and Sinossi of France. When we look at its routes of transmission, you have to read the question very carefully. Most common route is sexual. More than 90% cases transmit through heterosexual route. Least common is blood route. When we look at most dangerous route, that is blood, it has over 90% efficiency of transmission. Least dangerous is sexual. It has only 0.01 to 0.1% chances of transmission. So this is the paradox. Most dangerous has become least common due to screening, and least dangerous has now become the most common route of HIV transmission in our country. Most common opportunistic infection in world is pneumocystis cerevisiae pneumonia, and in India it is tuberculosis followed by candida followed by pneumocystis cerevisiae pneumonia. In India, for testing purposes, we use opt-out testing strategy under National AIDS Control Program of India. This disease has 3 screening tests together known as ERS battery. This is a combination of 3 tests: ELISA, rapid, simple. Once screening is done, a diagnosis is confirmed in the Indian program by Western blot assay, which is a protein based test. Then we look at, yes, a commonly asked topic, STD color coded kits. At primary level of healthcare, patient comes with signs and symptoms. We have no diagnostic facilities available for these sexually transmitted diseases or infections. So we directly diagnose on the basis of clinical symptomatology known as syndromic approach, and directly give this kit containing medications for consumption. Operating at secondary level of prevention, kits number, color and syndromes covered are asked in the exam. So kit number 1, gray. This kit covers which syndromes in the program? This covers urethral discharge, cervical discharge, anorectal discharge, and in males scrotal swelling. Kit number 2, green. This covers vaginal discharge. We are talking of trichomoniasis, commonest STI on this planet. Secnidazole is the drug inside. When we look at kit number 3, white. Kit number 4, blue. Kit number 5, red. All 3 of them are for genito-ulcerative disease. So what is the difference? Kit number 3, white, is genito-ulcerative disease, non-herpetic. Kit number 4, blue, is also genito-ulcerative disease, non-herpetic, but this includes patients who are allergic to penicillin. Kit number 5, red, is herpetic disease, herpes. Kit number 6. This is yellow. This covers lower abdominal pain, that is PID, pelvic inflammatory disease. And kit number 7, black. This covers inguinal bubo. These kits are available at STD clinic, now known as Suraksha Clinic, in the National AIDS Control Program of our country. This is Ebola virus. Ebola virus disease. Incubation period of this disease is 2 to 21 days, and predominant route of transmission is contaminated body fluids. Do we have a vaccine against Ebola virus? Yes, Zaire Ebola virus vaccine, which is a viral vector based vaccine. First viral vector based vaccine in use is Ebola virus. This also has been included in category A, bioterrorism agents, viral hemorrhagic fevers. This is, you can see here, bats. You can see here fruits, and these bats eaten fruits contaminated with bat secretions are reaching humans. So disease we are talking of, consumption of bat eaten fruits. Yes, Nipah virus disease. Nipah virus disease, which has been found in Kerala and West Bengal, is category C, bioterrorism agent. New emerging infections along with hantavirus disease. This is, you can see, spirochete spreading through rats' feces or other contaminated fluids like urine, and this is seen when people come in contact to them, mostly through water, like in floody situation. Disease is leptospirosis. This disease, where drug of choice is penicillin, for rodent control, zinc phosphide was used in Pathan Mitha district of Kerala after floods. So this is generally seen after disaster also, like earthquake or flood. Leptospirosis, any breach or cut in the mucosa of skin coming in contact with infected rat's urine leads to leptospirosis. This is monkeypox, a disease which started spreading globally recently, reached South Asia, reached India, mainly found epidemiologically in the group homosexuals, men having sex with men. Possible prevention is possible through usage of smallpox vaccine. Moving to non-communicable disease, looking at both of them separately, can you tell me which disease we are looking at? Yes, we are talking of the most common non-communicable disease among cardiovascular diseases, that is hypertension. Why I am saying it is common and it is going to remain common? Because BP increase with age. Image on the left side represents a rule of halves. Now what exactly is rule of halves? It says at any point of time, if you look at total population, around 50% of them would have hypertension, whether they know it or not. About 50% of them would be symptomatic. Of those symptomatic, 50% would seek treatment And of those who seek treatment, only 50% will get adequate treatment. Please remember this innermost circle. If I try to draw it here, this one, this represents adequate treatment getting 50% only. Rule of halves. On the right side, what we have is tracking phenomena of blood pressure. Now, what is the meaning of this tracking phenomena? See, BP will always increase with age, but it follows like track of an athlete. 4 children, 1, 2, 3 and 4 in childhood, their BP will keep on increasing. But look at child number 1, he was hypertensive in childhood, he will remain on the hyper side in adulthood. 4th child was hypo, he will remain hypo. Tracking phenomena. BP follows like track of an athlete, you have to remember. This is, yes, we are talking of disease, obesity. Instrument which is shown is her pendant calipers. Which is used to measure skin fold thickness as a measure of obesity. Best indicator of obesity is body mass index. Quetelet's index given by the formula weight in kilogram upon height in meter square. When we look at international classification of body mass index, you will find that normal lies between 18.5 to 24.99, 25 to 29.99 is pre-obese or overweight, 30 and above is obesity, below 18.5 is underweight. Obesity is further divided into 4 grades, 30 to 35 grade 1, 35 to 39.99 grade 2, 40 to 50 grade 3 morbid obesity, 50 and above super obesity. When we look at same obesity classification as per percentile of BMI, then please remember obesity is BMI above 95th percentile. 85th to 95th is overweight, 5th to 85th is normal, and below that is underweight. Indian classification, if you look, is only slightly different, where 18.5 to 22.99, this is normal, 23 to 25 pre-obese overweight, 25 and above is obesity in India, underweight is absolutely same below 18.5. Now this is body mass index. For obesity we also use skin fold thickness. It is weight independent, height independent indicator of obesity. We measure skin fold thickness at 4 sites: skin above biceps, skin above triceps, suprailiac, subscapular region. If their sum is more than 40 millimeter in boys or 50 millimeter in girls, obesity is present. Single site triceps is most sensitive. Skin fold thickness more than 18 millimeter in boys, 32 millimeter in girls is obese according to triceps. Then we have third indicator, that is Broca's index. Height in centimeters minus 100. Fourth, corpulence index. Corpulence index is actual weight upon desirable weight. Then ponderal index, where we have height divided by cube root of body weight and we use Lorentz formula also. Please remember, whereas BMI and ponderal index depend both on weight and height, if you look carefully, Broca's index and Lorentz formula are weight independent. Corpulence index, this is corpulence index, is height independent. Skin fold thickness is both height and weight independent. We move to blindness. When we look at blindness as a disease, we have National Program for Control of Blindness Visual Impairment definition in India as any person having visual acuity less than 3/60 in better eye, best possible correction. Even WHO blindness has same definition. So both these have same definitions now. Now categories of visual impairment based on visual acuity in better eye. All these are in better eye, best possible correction. 5 categories of visual impairment. We can remember the mnemonic LESMA. These are low vision, economic blindness, social blindness, manifest blindness, and absolute blindness. Low vision, less than 6/18 to 6/16 better eye, best possible correction. Economic is 6/60 to 3/60. Social is less than 3/60 to 1/60. Manifest is less than 1/60 to perception of light present. Absolute blindness is perception of light absent. If you look, economic blindness is work vision and social blindness is known as walk vision. New classification of WHO call them as visual impairment category number 1, 3, 4 and 5 respectively. The prevalence of blindness in India is 0.36%, where cataract 62% and refractive error 19.7% are the two common causes. Blindness besides cataract is also the commonest cause of visual impairment and low vision in India. Refractive error is the commonest cause of ocular morbidity in our country. Coronary heart disease, prudent diet. This is a dietary modification suggested by WHO to prevent and control coronary heart disease, where main aim is to reduce cholesterol HDL ratio to less than 3.5. How we are going to achieve it is by 6 different parameters. What are these 6 different parameters? Let's look at them. Number 1, total fat intake should be brought below 30% of total energy intake. Number 2, total saturated fat intake must be brought below 7%. Number 3, total salt intake must be brought below 5 grams a day. Number 4, total cholesterol intake must be brought below 200 milligram per day. Number 5, increase complex carbohydrates in the diet. And number 6, avoid alcohol. When we look at coronary heart disease, then its highest association, most direct association is with LDL. It should be kept below 100. Then we target HDL. It should be taken above 40 milligram per deciliter. And then we try for total serum cholesterol to be brought below 200 milligram per deciliter. When we look at Monica project, Monica project is monitoring of risk factors and determinants of cardiovascular diseases. So, risk factors and determinants of cardiovascular diseases. Please remember, friends, as a student, you have been putting so much of efforts. You have to keep reminding yourself, never say never, because fears like limits are just illusions. You have to move forward, come over your fears, and definitely success will be waiting for you right at the next corner. So do not stop, keep on moving, stay on course. National health programs, policies and legislations in our country. We start with the most important, most commonly asked health program, that is RNTCP, now known as National TB Elimination Program of India 2020 onwards. So what is shown on the screen is dots. Directly observed treatment, short course. Now if you look at history of this barometer of social welfare tuberculosis disease program, India started National TB Control Program 1962, which became revised National TB Control Program in 1992-93 by introduction of dots in the country. And recently, this has been converted to National TB Elimination Program of India, launched on 1st January 2020, where the target is to eliminate TB from India by the year. Initially, it was 2030. We have preponed the target by 5 years to 2025. We want to reduce incidence by 80% and we want to reduce mortality by 90% to achieve this elimination. So now this National TB Elimination Program has a logo also with a tagline TB मुक्त भारत, TB हारेगा देश जीतेगा. Now when we look at diagnosis under this program, the mainstay of diagnosis even today is sputum smear microscopy. Earlier it was done through ZN stain. Now program has introduced LED fluorescence microscopy also. Beside this, we have culture for diagnosis. Earlier the program was dependent on LJ medium, Lowenstein-Jensen medium. Now we have automated liquid culture also available. Then a big change in the program has been introduction of molecular assays. In molecular assays, the major test is CB-NAT, cartridge based nucleic acid amplification test. Mainstay of diagnosis in extrapulmonary TB in adults. Pulmonary TB in adults, if sputum smear comes negative, but chest X-ray showing presence of tuberculosis, and also in pediatric tuberculosis, it helps a lot. Otherwise, there is TrueNAT test and line probe assay. Drug susceptibility testing is offered to all DOTS patients in the country. Chest X-ray makes a return. So does tuberculin skin testing. We have LF lamp test, lipoarabino Manan test, lateral flow lipoarabino Manan test, which is used urine based test in HIV positive patients. And we also have CTB test when we have suspicion of latent tuberculosis. Please remember, when we look at serology for diagnosis of TB in India, there is a complete ban for its use in diagnosis of TB in the country. So mainstay test for diagnosis ZN stain and CBNAT today. We look at NICSHE. What is NICSHE? ICT enabled, information communication technology enabled surveillance system. Now what is done in NICSHE is, friends, in this surveillance system, all the DOTS patients through their clinics are joined through a software. NICSHE is basically an online software through Nirman Bhavan, Ministry of Health in Delhi. So real-time data generation is done. What is image on the left side? That is DOTS 99. Now please remember, DOTS 99 is actually ICT enabled adherence system. What is exactly DOTS 99? Patient of TB on DOTS, their mobile number is registered with our system. Every time they take out a tablet capsule from the blister pack, below this they will find a toll-free number on which they have to give a missed call after consumption of the medication. So we will come to know they have consumed the medication. High adherence and cure rates up to 99% have been found. So please remember, DOTS 99 is a type of adherence system. NICSHE is a type of surveillance system. Kshay Rog, like Tapedic, is a Hindi name of tuberculosis. FDCs, fixed dose combinations. When we look at fixed dose combinations, it has multiple advantages. It reduces pill burden. It reduces cost to the government of the country and the program. It reduces side effects for the patient, and it also reduces development of resistance. All this with reduced pill burden makes sure there is increased compliance of the patient. Please remember, there are different regimens for treatment of patients under National TB Elimination Program of India. They have now been standardized to reduce any confusion in the mind of caregivers. Now when we look at DOTS, we have DOTS category 1, DOTS category 2. 1 includes all the new patients. 2 include all the previously treated patients. But in both the groups, the regimen of treatment is absolutely same. And what is that regimen of treatment? That is 2 months of HRZNE plus 4 months of HRE. Total duration of treatment in these patients is 6 months. Now when you look at total number of doses, here it is 56 doses. This is, we are talking of intensive phase. 2 months into 4 weeks each, 8 weeks, 8 weeks into 7 doses every week, 56 doses. And here 4 months into 4 weeks, total 16 weeks into 7, that is 112 doses for each patient. Patient is allowed to take medication back to his home if he cannot come to your center for medication. That is non-DOTS. Here also we have 2 categories, ND1, ND2. ND1 is for seriously ill patients. Usually they are extrapulmonary. ND2 is for non-seriously ill patient. What are their treatment regimens? When we look at ND1, here the patient is given 2 months of SHE and 10 months of HNE. Total duration of treatment is 12 months. ND2 category patients are given 12 months of 2 drugs HNE. Again, total duration of treatment is 12 months. When we look at tuberculosis in pregnancy, the rule is start ATT as soon as possible, even in first trimester. Even this has now been made a standard regimen in our country. What is that? We give 2 months of HRE and 7 months of HR. Total duration of treatment is 9 months, which does not depend on time of diagnosis or delivery. In MDR TB also start ATT immediately, but after doing medical termination of pregnancy. In MDR TB, if mother does not allow MTP, which is actually falling under therapeutic or medical indication, then please remember you still have to start ATT, but take out ethionamide, kanamycin till delivery, substitute with PAS till delivery. In TB program, there has been introduction of weight bands. When you look these weight bands for adults, MDR TB and pediatric TB cases, then these are respectively 4, 5 and 6 weight bands. New drugs in TB program include only drug yet to develop resistance in TB, bedaquiline, and another new drug, delamanid. For both these drugs, conditional access regimens are used in the program. NPY, Nikshay Poshan Yojana, is monetary support to DOTS patients in the country in the form of nutritional support. This is given as rupees 500 per month to DOTS patients in the country. And not just DOTS patients, DOTS providers also get this. DOTS providers get this rupees 1000 on completion of category 1 or 2 treatment by the patient and rupees 5000 on completion of treatment of MDR or XDR TB. MDR TB, multi-drug resistant tuberculosis, is resistance to isoniazid and rifampicin both at the same time. What is X in XDR TB? XDR TB is extensively drug resistant tuberculosis, which definition wise includes no doubt MDR TB. So diagnosis includes resistance to both isoniazid rifampicin plus any one fluoroquinolone, ciproflox, oflox, sparfloxacin, or second line injectable out of kanamycin, amikacin, capreomycin. Now linezolid and bedaquiline have been included in this resistance. Please remember X is extensively drug resistant tuberculosis. Besides the definition of blindness, categories of visual impairment, most common causes that we have already discussed, you should know Vision 2020 in this program of National Program for Control of Blindness and Visual Impairment. Vision 2020 wanted to eliminate all causes of avoidable blindness by the year 2020. Avoidable include preventable, vitamin A deficiency commonest in children, and curable, cataract commonest in adults. Now when you look at this Vision 2020, it has two different subtypes. One is for world, Global Vision 2020. It includes 5 diseases: cataract, refractive error, low vision, trachoma. It includes childhood blindness and onchocerciasis. In contrast, when we look at Indian Vision 2020, first 4 diseases are same: cataract, refractive error, low vision, trachoma, childhood blindness. But instead of onchocerciasis, which does not exist in India due to lack of the vector black fly simulum, we have 3 additional diseases: glaucoma, corneal blindness, and diabetic retinopathy. Now, how we are delivering this Vision 2020 services in the country? To understand this, let us look at a pyramid where we have 5 levels of healthcare for this program. So, we have lowest primary level, where we have vision centers. These vision centers have been developed 1 per 50,000 population, and there are 20,000 such numbers in India, to be managed by paramedic ophthalmic assistant of PHC. Above that, we have secondary level of healthcare, where we have created service centers. Service is the cataract surgery to be given by ophthalmologist at CHC. Then we have tertiary level, medical college, ophtha department. Then we have centers of excellence and apex. Out of the two, one is Rajendra Prasad Institute of Ophthalmic Sciences, AIIMS, Delhi. There is LV Prasad Institute in the southern part of the country. So we have 20,000 vision centers, 2,000 service centers, 200 medical colleges, 20 centers of excellence, and 2 apex. When we look at population norms, service center is 1 per 5 lakh population. This is 1 per 5 million population. Centers of excellence 50 million, apex 500 million population. Many international health organizations barring UNICEF are a part of Vision 2020. We are looking at disease. You can see leishmaniasis, that is Kala Azar. Kala Azar is a disease which is caused by Leishmania donovani, and its vector is sand fly, biological name phlebotomus. When we look at Kala Azar, this is covered under the program National Vector-Borne Disease Control Program of India, where drug of choice is liposomal amphotericin B. A combination of perimomycin and miltefosine is number 2 choice. Diagnosis is based on serologically RK39 antigen, Montenegro test, Leishmanian antigen, 48 to 72 hour reading is the immunity status test of this particular disease. When we look at this National Vector-Borne Disease Control Program, the commonest vector-borne disease we discussed is malaria. So, under National Vector-Borne Disease Control Program, for the disease malaria, we have dipstick test for diagnosis besides peripheral blood smear, which is based on histidine rich protein type 2 of Plasmodium falciparum antigen for diagnosis. Under the same program, please remember, for dengue diagnosis serologically, we are using NS1 antigen. Now, what is the advantage of NS1 antigen? It can come positive in first 7 days, 3 days, or even first day of illness. When we look at all these vector-borne diseases, actually National Vector-Borne Disease Control Program of India covers 6 diseases. So, malaria, dengue, chikungunya fever, Kala Azar, filariasis, and Japanese encephalitis. Malaria we'll discuss shortly. Others we have discussed. For filariasis, the drug of choice is diethyl carbamazine. Peripheral blood smear taken just before midnight is used for diagnosis. And this filariasis lymphatic Culex quinquefasciatus is the vector commonly known as Culex fatigans. Brugian filariasis is transmitted through Mansonia mosquito. Now looking at this is Plasmodium falciparum. Now when you look at treatment of malaria in the country, then Plasmodium vivax, Plasmodium ovale are same. Both of them, the drug of choice is chloroquine along with primaquine. But when we look at Plasmodium malariae and Plasmodium falciparum, for these two, the drug of choice is also same, and that is artesunate based combination therapy along with primaquine. If the person is from other parts of India, he is given a 3-drug combination, artesunate based combination therapy with sulfadoxine pyrimethamine. But if the same person is from Northeast India, then he or she is given artemether combination therapy with lumefantrine, 2-drug combination. All of them are given along with primaquine. Only primaquine is not given in pregnancy, and in first trimester it is found quinine is better as compared to ACT. Also please remember, short-term chemoprophylaxis is through doxycycline, long-term chemoprophylaxis is through mefloquine. Insecticide treated bed nets, cyflothrin deltamethrin, 6 months life, long lasting life. Insecticide treated bed net goes up to 3 years after using a chemical binder in them. And this is, yes, the logo of National Leprosy Eradication Program of India. So we have hand holding a flower or lotus, sun in the background. Now National Leprosy Eradication Program, if you look, the treatment is MDT, multi-drug therapy, which is further divided into 2 parts, paucibacillary leprosy treatment, multibacillary leprosy treatment. Now what is this division of pauci and multi based on? It is based on number of skin lesions, up to 5 pauci, more than 5 multi. And if there are exactly 5 skin lesions, they also go into paucibacillary leprosy. When we look at nerve involvement, both may have. Pauci is either not having nerve involvement, or if it is there, it is maximum 1 nerve. But multi has minimum 1 nerve. So it may be 1, 2, 3, 4 or even more number of nerves. All of us know most common nerve affected is ulnar. And how do we test for ulnar nerve that it is affected by leprosy? We look at thickening on the medial epicondyle. So cord like thickened nerve is virtually diagnostic of leprosy. Then the classification. Leprosy is the only disease where name of classification is asked, most commonly classified by Ridley-Joplin classification. Now when we look at Ridley-Joplin classification, it is a type of, if you look, Ridley-Joplin classification is a type of immunohistological classification, which has got 5 immunohistological subtypes. These are tuberculoid, borderline tuberculoid, borderline lepromatous leprosy. Now out of them, highest bacillary load, most infectious, lepromatous leprosy. Least bacillary load, highest cell mediated immunity, tuberculoid. And when we look at most common subtype in India, that is borderline tuberculoid. Lepromin test is a test of cell mediated immunity. So even strongly positive lepromin test is seen in tuberculoid leprosy. But in program, we are treating them not as 5 but as 2 types, Psm multi. So when we look tuberculoid and borderline tuberculoid are Psm, other 3 are multibacillary leprosy. Drugs which are used in treatment of Psm and multi, 2 drugs in Psm, 3 in multi. 2 in Psm are Dapsone, rifampicin, and in multibacillary besides Dapsone, rifampicin, clofazimine is also used in treatment. Now please remember, India has not yet adopted the WHO uniform MDT guidelines. They are saying it's likely to be implemented from 2025 onwards. As and when the guideline is released, I'll definitely update in the Cerebellum app also and on social media also. Duration of treatment. It is currently in Indian program 6 months for paucibacillary, 12 months in multibacillary, and then when we look at follow-up, it is once a year for 2 years in Psm, 5 years in multi. Please remember, completion of treatment is almost a guarantee of cure in leprosy. Some person lesions are still persisting after completion of treatment. Reassure the patient. Lesions will slowly disappear over time. Just come to our clinic for follow-up once a year for 2 years after Psm treatment, once a year for 5 years after multibacillary leprosy treatment. Now this is what we are talking of is MDT. If a patient cannot come to your clinic for direct observation like in TB, here it's not known as direct observation, here it is known as OMS. What is OMS? This is once a month supervised therapy. So supervised therapy, just like direct observation in TB, patient has to come to your clinic and consume the medication in front of you, not directly supervised, is Dapsone. So please remember, rifampicin and clofazimine are directly supervised. Now, if patient cannot come to your clinic, will you give him medication to take back home? Yes, that is known as accompanied MDT. So what is accompanied MDT? Any person, any responsible person rather, on behalf of patient can collect the whole medication for patient to take back home. Family member, village panchayat head, school master, teacher, postmaster, any responsible health worker in the village, ASHA worker could also be given the responsibility to collect the medication on behalf of patient. What is uniform MDT? Uniform MDT is all patients of leprosy, WHO recommend, should be given all the 3 drugs, Dapsone, rifampicin, clofazimine. Moving further, looking at the treatment in the leprosy program, multi-drug therapy, when you look, there are colored blister packs available. So we have green colored blister pack. This is for paucibacillary leprosy treatment of adults. Red colored, this is multibacillary leprosy treatment of adults. Blue colored blister pack, this is paucibacillary leprosy treatment of children. And yellow colored blister pack, this is multibacillary leprosy treatment of a child. So if you look carefully, we have separate blister packs for Psm multi, adult and child in our country right now. What is DORS? Directly observed rifampicin using chemoprophylaxis. This DORS is actually post-exposure prophylaxis using rifampicin in a single dose according to the body weight. And this inclusion criteria include exposure more than 3 months, exposure more than 20 hours a week during that time, and age 2 years and above. National Health Mission, largest public health umbrella health program which encompasses all the major health programs in our country. National Rural Health Mission was launched in the year 2005, meant to be running in the country till 2012. At the same time, National Urban Health Mission was launched in the country. Now, after 2005, both of them were combined to give rise to the common program National Health Mission 2013 onwards. Now, why I am saying National Health Mission is the largest public health mission program of India? Because it is a combination of multiple programs, both from communicable disease side as well as non-communicable disease side. Like it includes National TB Elimination Program, National Leprosy Eradication Program, National Vector-Borne Disease Control Program, and RCH program from the communicable disease side. Non-communicable disease side, it includes National Program for Control of Blindness and Visual Impairment, National Tobacco Control Program, National Program for Health Care of Elderly, National Iodine Deficiency Disorders Control Program, National Program for Control of Diabetes, Cardiovascular Diseases, Cancer and Stroke, National Mental Health Program, and National Program for Control of Filariasis, and National Program for Prevention and Control of Fluorosis in the country. From National Health Mission, we look at the largest public health program component. So, which public health program is the largest component of National Health Mission? That is RCH program, Reproductive and Child Health Program of India. Now, programs never stop. Their names only keep on changing with time. First country in the world to start National Family Planning Program was India in 1951. As time progressed, it gave rise to Child Survival Safe Motherhood Program in 1992. And what was the change in the program was the addition of mother and child health. As program evolved more, it gave rise to Reproductive and Child Health Program of India in the year 1997, and this was possible by addition of reproductive health and sexual health in the program. Now, when we look at RCH program, what is the strategy which is being used in the Indian program for RCH? That strategy is known as RMN CH plus A strategy. This is actually a combination of different components in the program. So, we have focus on reproductive health, maternal health, N is newborn health, CH is child health, and there is a separate component plus A. Special importance has been given to adolescent health. Related to these strategies, several components, several new sub-programs have been launched in the country. The major program is JSSK. What is JSSK? This is Janani Shishu Suraksha Karikram. So, it has two target beneficiaries, Janani, that is mother, and Shishu, that is newborn. So, several components are there for these two targets, mother and newborn. When we look at maternal component, we have got free transport to and fro from the health center to house, Asha worker will accompany, free delivery, free drugs, free diagnostics, free blood transfusion, and there is now also a provision of free diet in this program, which is 3 days for normal vaginal delivery and 7 days for cesarean section. Now, Shishu component is the newborn component. This also includes free drugs, free diagnostics like maternal component, free surgery, free blood transfusion if required. This also now includes a lot of smaller components, under which 3 centers have been created at 3 different levels of MCH. We have newborn care corner at MCH 1 level, newborn stabilization unit at level 2 of MCH, and level 3 of MCH we have specialized newborn care unit. Level 1 MCH is primary health centers. Level 2 MCH is 24/7 PHC and CHC. Level 3 is district hospital line, first referral unit. When we look at total number of provision of beds at specialized newborn care unit, there is a provision for total 12 to 20 beds under this strategy. Then we have RBSK. Now, what is this RBSK program of India? This is Rashtriya Bal Swasthya Karyakram. So, target beneficiary is Bal. Bal means child, and child in Indian program is 0 till 18 years of age. This program is characterized by its 4 Ds. Now, what are these 4 Ds of RBSK program? These 4 Ds include diseases, deficiencies, defects, disabilities and developmental delays. Now, overall this program include 30 or more disorders for which screening is done by a mobile clinic. This mobile clinic is handled by a Ayush medical officer. So, this is basically child health screening and early intervention program. Then was launched under NHM RKSK program of India. What is RKSK? This is Rashtriya Kishore Swasthya Karyakram. Kishore means the target beneficiary is, yes, adolescent, and age of adolescent in India is 10 to 19 years. This program is characterized by 7 C's. Now, what are these 7 C's in the RKSK program of India? These 7 C's include clinic, community, communication, content, convergence, coverage and counseling. Rashtriya Kishore Swasthya Karyakram. Then came NSSK. NSSK is Navjat Shishu Suraksha Karyakram. So, when we look at Navjat Shishu, this means early newborn. First 7 days of life. This is basically a training program on care and resuscitation of newborn for all levels of healthcare personnel. Then HBNC. What is HBNC? This is home based newborn care, which includes postnatal visits by ASHA worker in the healthcare system of India. These postnatal visits are 6 in cases of institutional deliveries, 7 in cases of home deliveries. These have to be taken on day 3, 7, 14, 21, 28, 42 in cases of institutional delivery. In home deliveries, additional visit is also on day 1 of the delivery. Then we have FIMNCI program. FIMNCI, facility based integrated management of neonatal and childhood illness, where the target beneficiary is taken as children 0 to 5 years. Here 0 to 2 months is young infant, 2 months to 5 years is taken as child, and 5 common causes of neonatal and childhood illness are included in this program. This 5 include pneumonia, diarrhea, measles, malaria, and malnutrition along with their complications. It has 6 steps in sequence: assess the child, classify illness, identify treatment, treat the child, counsel the mother, and give follow-up care. Then also NRC, Nutritional Rehabilitation Center, has been established in this program, where the target beneficiary is children up to 5 years for management of severe acute malnutrition. Anemia Mukt Bharat program. Now we move to the new programs. It wants to reduce prevalence of anemia by 3% prevalence points per year from the year 2018 to 22. This program is based on 6 by 6 by 6 strategy. Now what are these 6 by 6 by 6? This includes 6 interventions, 6 institutional mechanisms, and 6 the beneficiaries who are visible in the logo also. When we look at these 6 beneficiaries, questions usually come on the iron folic acid supplementation. Let's look at that. When we look at iron folic acid composition, children below 5 years are given 20 milligram elemental iron, 100 microgram folic acid. 5 to 9-year-old children 45 milligram elemental iron and 400 microgram of folic acid. All other 4 groups, 10 to 19-year adolescents, reproductive age group 20 to 49 females, pregnant females, lactating females, get same iron and folic acid content. 60 milligram elemental iron, 500 microgram of folic acid. The frequency is different. Bi-weekly, it is given to children below 5 years. Then it is given on a weekly basis to children 5 to 9, adolescents, and reproductive age group non-pregnant, non-lactating. Pregnancy and lactation, it is given on a daily basis. Now, children below 5 years get it in the form of a syrup, but all other get it in the form of a tablet. So, pink tablet, this is meant for children 5 to 9 years. Blue colored tablet, this is for adolescents. Other get red colored tablet for this program. It has been linked with National Deworming Program. Biannually it is done. From Anemia Mukt Bharat, we move to another new program, that is Swachh Bharat Mission. Now Swachh Bharat Mission, the main aim of this program is or was to make India open defecation free by the year 2019. And how it was envisaged we are going to achieve it is by construction of 12 million toilets. Another new program has been Ayushman Bharat program. Now Ayushman Bharat program has 2 components. What are these? First component is Health and Wellness Center. This center has been mainly created at sub-centers in the country and few PHCs. This is to be manned by community health officer, a BSc nursing graduate, somewhere Ayurveda doctors have also been roped in. And here there will be a provision of all the required diagnostic services and essential drug supply. Second part of this program is Pradhan Mantri Jan Arogya Yojana. Now, when we look at Pradhan Mantri Jan Arogya Yojana, this is actually a hospitalization cover, tertiary level and secondary level hospitalization, which is totally free. No premium would be charged from the below poverty line population of our country. So 10.7 crore families, approximately 50 crore population is likely to be benefited by this. Under this program, how much is the cover given per year? Insurance cover given for hospitalization is rupees 5 lakh per family per year. This is totally paperless, cashless scheme also. Any private institution, government are by default, any private institution can get itself empaneled under this Ayushman Bharat if it has a provision of minimum 10 beds for admission of patients. Poshan Abhiyan, earlier known as National Nutrition Mission. The main aim of this program is to or was to make India malnutrition free by the year 2022. Now, for this, 4 disorders have been targeted. We can remember, as I discussed in the main videos and mission videos, by the mnemonic SULA. These are stunting, underweight, undernutrition, low birth weight, and anemia. We have targeted in all the 4 disorders that how much we are going to reduce their prevalence every year. So we have targeted for stunting 2% prevalence reduction every year. Similarly for undernutrition, low birth weight also. For anemia, we have targeted a 3% reduction in prevalence every year. This was the basis of starting Anemia Mukt Bharat program in the country. National Iodine Deficiency Disorders Control Program. If you look at level of iodization of salt in India, salt is the major source of iodine for us in India. So when we look at production level and consumer level, it is 30 parts per million and 15 parts per million respectively. If you look at principal impact indicator of this program, that is urinary iodine excretion levels measured in pregnant females over a 24 hours period. This is, as written in the center, the IDSP program of India. What is IDSP? This is Integrated Disease Surveillance Program. This program encompasses or includes 3 types of surveillances. These are regular surveillance. Under regular surveillance, common diseases of India are included. So this includes vector-borne diseases, malaria, dengue, water-borne diseases, typhoid, cholera. It includes road traffic accident, meningococcal meningitis. It includes plague, viral hemorrhagic fevers, and also respiratory diseases like upper respiratory tract infection, tuberculosis. Beyond regular surveillance, second type of surveillance undertaken in this program is sentinel surveillance. This includes mainly 5 types of sentinel surveillances, that is for HIV, hepatitis B virus, hepatitis C virus, air quality, and water quality. Third type of surveillance in this program is periodic surveys. These periodic surveys are undertaken for 2 parameters. One is non-communicable disease risk factors, and second is anthropometry. IDSP has got 3 types of forms. SPL, special mnemonic we can remember. S form, P form, and L form. Now, what are these S, P and L form and who they are filled by? When we look at S form, this is syndromic diagnosis based on symptoms. This is filled up by health workers in the field. Then the patient is brought to health center, where P form, P is presumptive diagnosis. This is done by you, medical officer of the primary health center. And finally L form, where laboratory confirmed diagnosis is required. We have laboratory staff who will fill this form for the program operating at secondary level of prevention. This is the logo of ICDS program of India. What exactly is ICDS, friends? Integrated Child Development Services, 1975. Now, when we look at this program has got 4 target beneficiaries. So, who are the 4 targeted beneficiaries of this program? These 4 beneficiaries include children 0 to 6 year, then non-pregnant, non-lactating 15 to 49 reproductive age group females, then pregnant and lactating women, and finally 11 to 18 year adolescent girls. What are the services provided under this program? If you see, services under this program include non-formal preschool education. Please remember, it is not a school. So, non-formal preschool education, health education. This also includes immunization services, family planning services, referral services, and free food supplementation. What is the heart of ICDS? Heart of ICDS is Anganwadi, where all these services would be delivered. Now, one Anganwadi in India is for a population of 400 to 800 in plains, 300 to 800 in the hilly areas. When we look at free food supplementation, all these beneficiaries get calories and proteins in a fraction means of the daily requirement. Calories given are daily 1/3 of the daily requirement, proteins are given 1/2 of the daily requirement. Now, when we look at infrastructure of this program, other programs are running district wise. Only this program is running block wise in the country. So, we have community development block. One such block comprises of roughly 100 villages, approximately 1 lakh population. One community development project officer is actually in charge of 4 Mukhya Sevika, who are in turn in charge of 20 to 25 Anganwadi centers. So, one community development project officer is indirectly in charge of 100 Anganwadis. Look at this logo. This is midday meal program. You can see children sitting on a round table, thali kept in front of them. They are eating food. So, this is also free food supplementation, just like ICDS. What is the difference? ICDS services are provided through Anganwadis. This is covered by Ministry of Women and Child Development. In contrast, midday meal program falls under Ministry of Human Resource Development. When we look at calorie and protein supplementation given to school children under midday meal program of India, then please remember it is exactly like ICDS, 1/3 of daily calorie requirement, 1/2 of daily protein requirement. Here target beneficiaries are children in the primary classes and upper primary classes. Primary classes children are given 450 kilocalories and 12 grams of protein per day. It is given as 700 kilocalories and 20 grams of protein per day in upper primary classes. For this, 100 grams of cereals per child per day are marked in primary section and 150 grams of cereal per child per day in upper primary class students. Please remember, this meal is a supplement. It is not a substitute. Menu should be changed frequently. Please remember, it should be made from locally available foods. And also remember, its initial purpose was to increase the enrollment in the schools. Looking at some other new programs, one such program is Suman. Now, when you look at Suman program, what exactly is this? This is Surakshit Matritva Ashvasan. Suman. Under this program, we have targeted to achieve zero maternal and newborn deaths in the country, where BMONG packages, CMONG packages and basic essential care services package would be given to mother and newborn. PMSMA. This is as written on the screen in front of you, Pradhan Mantri Surakshit Matritva Abhiyan. Here it has been planned that on 9th date of every month, there will be free obstetric care given in second and third trimester by private practitioners. PMMVY. This is Pradhan Mantri Matru Vandana Yojana, where the beneficiary mother will get a total of 5,000 rupees divided into three parts. First 1,000 rupees she would get when she gets registration of her pregnancy done. Then the second tranche of rupees 2,000 would be given to her when she makes minimum one antenatal visit to the center. And finally, the last tranche of 2,000 rupees would be given if she gets birth registration of the newborn done and child gets at least BCG, DPT, OPV and hepatitis B. SANS program. What is SANS program? This is social awareness and action plan to neutralize something successfully, that is pneumonia. In fact, we want to reduce pneumonia deaths in the country to less than 3 per 1,000 live births under this program. NREGA. NREGA is actually an abbreviation of National Rural Employment Guarantee Act 2005, where government gives the guarantee of employment to below poverty line family which is totally unemployed, but employment would be given to maximum one member per family only. Minimum 100 days a year. This will include manual, unskilled labor work, where they will be provided wages on a daily basis at standard benefit rate. Job card within 15 days of application, and job will be given within 5 kilometers radius of the house. Medical Termination of Pregnancy Act 1971 has undergone a lot of modifications, including recently. So when we look at this MTP Act in its current format, it is allowed, medical termination of pregnancy is allowed for 4 indications, and these indications are heads. This is humanitarian. If pregnancy is a result of rape or sexual assault, eugenic, any genetic anomaly in fetus, therapeutic, also known as medical indication, any risk to life of mother if she carries on with pregnancy, and social, generally due to contraceptive failure. Then it could only be done by 3 years degree in gynae-obs, 2 years diploma in gynae-obs, or 6 months JRship someone has done in the Department of Gynae-obs. After academic qualification, there should be requisite experience of 20 to 25 supervised MTPs. Center should be authorized, indication should be there, and comes finally the period of gestation for which it is permitted. It is divided into 2 parts, low risk, high risk. When we look at period of gestation, it is permitted in India up to 24 weeks period of gestation only. Low risk is 0 to 20 weeks. High risk is 20 to 24 weeks. Low risk, only one doctor's opinion is sufficient. High risk pregnancy, 2 doctors are minimum required. Beyond 24 weeks also, MTP may be permitted by court, but there should be involvement of the medical board who will decide if it is required or not, usually in the cases of substantial fetal anomalies. Demography, demography. This is population study. So, scientific study of human population, which we generally study as part of 5 demographic processes. These 5 demographic processes are fertility, marriage, mortality. Please remember morbidity is not included. Then migration, which is physical, geographical from one place to another, and social mobility, movement of a person across social class or socio-economic status. 2 important basic demographic parameters are crude birth rate, crude death rate, which are measured as number of births and number of deaths measured per thousand mid-year population. Mid-year population of a country is on 1st of July. When we look at India currently, crude birth rate is around 19 per thousand and crude death rate is around 6 per thousand mid-year population. Crude birth rate minus crude death rate, this gives you growth rate. You multiply that by 10 to convert it into percentage, and also this is represented by demographic gap. There are 5 stages of demographic cycle. Now, when we look at these 5 stages of demographic cycle, what are these actually based on? These are based on crude birth rate and crude death rate. Whenever a country is formed for the first time, stage 1, they have high birth rate, high death rate. High births, high deaths, population will remain stationary at high level. This is known as high stationary stage of demographic cycle. In stage 2, what happens? Birth rate remains high, but death rate start declining for the first time. Why will this happen in stage 2? Because improvement in medical facilities. So, birth rate is high, death rates have started reducing. Population will expand. This is known as early expanding stage. After early expanding stage comes the third one, that is late expanding stage. Now, why population expand in late expanding stage? Death rate is already reducing, but birth rate starts reducing for the first time due to family planning program in the country. Both are declining, but still birth rate is higher than the death rate, population will expand. Finally, both birth rate, death rate will become low someday in stage 4. Population will again become stationary. This is known as low stationary stage. And finally, in stage 5, what happens? Birth rate declines to go even below the death rate. So, higher deaths, lesser birth, population will decline. This 5th stage is declining stage. Many European countries, France, Germany, Hungary, and here in this part, Singapore, Japan, Russia, they have gone into the declining stage. When we look at India, India is currently in stage 3, late expanding stage, where both birth rate and death rate are declining year by year. When we try to see from stage 1 till stage 4, this part, now you can see a country is moving from high birth rate, high death rate to low birth rate, low death rate. This is known as demographic transition. And when we look at in this diagram, demographic gap, you can see demographic gap is maximum here, right? Late stage 2. It starts contracting here. So it starts contraction. We see minimum demographic gap in stage 1 and 4. And finally in stage 5 we see negative demographic gap. When you look at the same diagram, again demographic cycle. Now in this particular diagram, you can additionally notice that there is a red line also. This indicates total population. So it increases in stage 2 and 3. It remains almost stationary in 1 and 4 and it starts declining in stage 5. This diagram is population pyramid, also known as age sex pyramid, which is drawn between age 5 yearly intervals on y-axis and sex female male percentage population on the x-axis. This is actually a type of double histogram. Now when we look at population pyramid, you should know about its 3 properties, how a developing and a developed country are different from each other. When we look at the shape of a population pyramid of a developing and developed country, for a developing country, it is somewhat like this. This is known as an upright triangle having a broad base and a narrow top. Why broad base? Because we have more children in developing countries, more population in younger age group, high fertility levels, high dependency ratio of young age. In contrast, a developed country pyramid is like this. This is known as spindle shape, which is having bulge in middle. More population is in the middle part, economically productive age group. So shape represents fertility pattern of a country. Developing countries high fertility, developed countries low fertility. After shape, we look at span or height or length of the pyramid. When we look at span, you will find that developing countries pyramids are slightly shorter, whereas in contrast, the developed countries pyramids are a bit taller. Reason is life expectancy, lesser in developing country, higher in developed country. So span is indicative of life expectancy. And finally, we look at symmetry of the pyramid. If you look developing and developed country pyramids are asymmetric, developed country pyramids are symmetric. So symmetry is representative of sex ratio. So we have lesser females, unfavorable sex ratio in developing countries as compared to developed countries. So I'll again repeat, span is life expectancy. Shape is fertility, symmetry is sex ratio. Based on this, you should be able to identify, are we looking at a developed country or a developing country's population pyramid? So this is actually the pyramid of a developing country, you can see. Why? It is upright triangle, you can see, with broad base, more children, high fertility, high young age dependency, and a narrow top. Also, you can see that there is a gap here representing an unfavorable sex ratio, asymmetric pyramid, and its shorter. Highest life expectancy age group is around 75 to 79 only. Now we come to the data collection systems of India. Biggest data collection system of India, Census of India, which is undertaken once every 10 years. First ever census was in the year 1871 and first disability census was 1881. Last census was 2011, 15th census of India. These censuses are undertaken by Ministry of Home Affairs. Now, when we look at key parameters, then we should know sex ratio, number of females divided by number of males into 1000, value 943 females per 1000 males in our country. It is highest in Kerala, lowest in Daman and Diu. When we look at CSR, child sex ratio, that is almost same, only to be considered in the age group 0 to 6 years. So female children 0 to 6 year divided by male children 0 to 6 year into 1000. This is 919 female children 0 to 6 year per 1000 male children 0 to 6 year. Highest in Mizoram, lowest in Haryana. When we look at literacy rate in our country, literacy rate is number of literates. Literate means who can read, write and understand any one language of our country, divided by total population aged 7 years and above into 100. Answer comes in percentage, it is a proportion. Total 74% of Indian population is literate, slightly higher in males 82%, slightly lesser in females 65%. It is highest in Kerala 94%, lowest in Bihar 64%. When we look at annual growth rate of India, it is 1.64%, making India in very rapid growth phase. India's population doubling time is 35 to 47 years. Also, we should know in India 3% population is infants. We can say pregnant also women at a given one time constitutes 3% of total population of India. We have 10% population comprising of children 0 to 5 years. 31.3% population is urban and above 8% population is geriatric. Geriatric is aged 60 years and above in the country. When we look at censuses of India, you will find we are a developing country, so our population is continuously increasing. But once our population was found to be lesser than the previous census, that was 1921 census, known as therefore the big or the great divide in the censuses of our country. So 1911 to 1921 population actually decreased. Every census we declare India's population count, known as census top date, on 1st of March, exactly midnight. Another data collection system also undertaken by Ministry of Home Affairs is sample registration system once every 6 months. This is considered India's most accurate data collection system of India because it is India's only dual record data collection system of India. 2 times data is collected. Here we measure MMR in a separate SRS report in contrast to IMR, under 5 mortality rate, neonatal mortality rate, growth rate, crude birth rate, and crude death rate in our country. We also have National Family Health Survey, which is undertaken once every 5 years. National Family Health Survey 5 2019 to 21 has been completed, which mentions that we have attained a total fertility level of 2 TFR rate. District level household survey. This data collection system is used to assess district level data, including routine immunization coverage levels. Vital registration system of India. 3 vital events are mandatory to be registered in India: births within 21 days, deaths within 21 days, and marriage registration varies from part to part. Birth registration is the responsibility of hospital or institution where delivery is done. If NRI couple delivers a child abroad, they want the birth registration of the child in the country. It should be done within 60 days of arrival in the country. TFR, GRR, NRR. Total fertility rate is total number of children born to a couple in their entire reproductive lifespan. GRR, gross reproduction rate, is total number of girl children born to a couple in their entire reproductive lifespan. NRR, net reproduction rate, is again same, total number of girl children born to a couple in their lifespan minus mortality. Mortality is taken into account. You can say living girl children. So we can see net reproduction rate or gross reproduction rate is approximately half of total fertility rate. Total fertility rate is also known as completed family size. Please remember, crude birth rate is approximately 8 times total fertility rate plus 1. NRR is one of the most important demographic fertility indicators. To achieve NRR of 1, because originally the TFR goal was 2.1. To achieve NRR 1, contraceptive usage or prevalence rate should be more than 60% couple protection rate, and ideally contraceptive advisable is sterilization, especially vasectomy. Child women ratio. This is a formula where we have children 0 to 4 year total per 1000 total women in reproductive age, mid-year population. When we look at general fertility rate, this is total number of live births per 1000 women in reproductive age again. Dependency ratio is economic dependency. How much non-earning depend on earning for survival. So this includes non-earning population is taken as below 15 years and more than 65 years divided by rest of the population. Family planning contraception. We look at first definitions. Conventional contraceptive does not mean contraceptives which are old like Lippis loop. These are contraceptives which are used at the time of intercourse. So which contraceptives are conventional in nature? This would include male condoms. And if I make a list of barrier methods, female condoms, diaphragm, vaginal sponge, then please remember not all barrier methods are conventional, only male condoms are. Female condoms, diaphragm, vaginal sponge do not fall in this category. Why? Female condoms have to be inserted 2 hours prior to intercourse, should not be removed for 2 hours later. Diaphragm should be inserted 6 hours prior to intercourse, should not be removed for 4 to 6 hours till later. Vaginal sponge inserted 4 hours prior to intercourse, should not be removed for 4 hours later. So it is only male condoms which are exactly used at the time of intercourse. So please remember, not all barrier methods, only male condoms are conventional in nature. Also, another example of conventional contraceptive is spermicides. Now, why we are saying that spermicides are also conventional in nature? They also act only at the time of intercourse. And what is the chemical inside? That is non-oxynol 9. And what is the mechanism of action of non-oxynol 9? How does it kill the sperm? It ruptures plasma membrane of acrosomal cap. Death and lysis of the sperm occurs. This is conventional contraception. In contrast, what is interception? Interceptive is contraceptive which is used after intercourse. So we can say that this is a synonymous term to emergency contraception. So which 5 major emergency contraceptives are recommended in RCS program of India? This includes combined oral contraceptive pills, progesterone only pills, IUD, RU486 that is mifepristone, and high dose of estrogen. When we look at combined OCP, we use how many pills for emergency contraception and in how much time it should be used. It has to be used within 72 hours of intercourse. Progesterone only pills also within 72 hours. IUD within 5 days. RU486 within 72 hours. And high dose estrogen is continuously used for 5 days. I was asking, combined OCPs when used as emergency contraceptive, how many pills are used? Total used are 8 pills. 4 pills followed by another set of 4 pills. There should be an intervening gap of 12 hours. Both the set 8 pills total should be completed within 72 hours. This is also known as USP and Lancy regimen of contraception. When you look at progesterone only pills, they are used total 2 pills. Intervening gap between 1 and 1 pill is 12 hours. Both should be completed within 72 hours. Which of them is having highest efficacy as interceptive? That is IUD. Best. When we look at efficacy, highest means least failure rate. But more commonly recommended in Indian program is progesterone only pills. We look at eligible couple. It is a currently married couple where the wife is in reproductive age group. They should be targeted for contraceptive services in RCH program. We believe around 150 to 180 eligible couples per 1000 population in India is the eligible couple rate in our country. Couple protection rate. How many couples are protected against pregnancy? So it is total number of protected couples. Protected couples means, yes, using any one method of contraception out of total eligible couples into 100. Numerator is a part of denominator. Multiplier is 100. Couple protection rate is a misnomer. It is not a rate. It is expressed in percentage. It is a proportion. Couple protection rate minimum 60% is required to achieve NRR 1. According to the latest NFHS 5 data, couple protection rate of India, contraceptive prevalence rate they have calculated is more than 67% currently. Pearl index is used to measure contraceptive efficacy, or you can say contraceptive failure rate. How do we express it? It is expressed per 100 women years. Now, if you look at the formula of Pearl index, it is total number of accidental pregnancies. What is the meaning of accidental pregnancies? Which occur despite using the contraception, divided by total months of exposure. Total months of exposure to contraception means total months of usage, and it has a unique multiplier 1200. When we look at male condoms, their 2 to 14 is the Pearl index. Lower than female condoms 5 to 21. When we look at vaginal sponge, 9 to 20 per 100 women years. IUDs 1 to 5, OCPs 0.1 to 2, and sterilization 0.1 is the least Pearl index. Sterilization vasectomy is the contraceptive with highest efficacy. Besides Pearl index, we can also use life table analysis for contraceptive failure assessment. It is calculated per single woman month of use. This is a female condom. What are its differences technically from a male condom? When we look, female condom is longer, having 2 rings. Male condom is shorter with 1 ring at the end. Male condom is translucent because it is made of latex. This is transparent because it is made of polyurethane or nitrile polymer. Difficult technique of insertion. Repeated practice to be taught by physician makes it a higher failure rate, a Pearl index of 5 to 21 per 100 women years. It is a reusable contraceptive, and yes, it gives a much higher degree of protection against HIV and STD transmission. This is a non-conventional contraceptive to be inserted 2 hours prior to intercourse, should not be removed for 2 hours later. This is contraceptive today. Today is a type of, in Indian program, a vaginal sponge. A vaginal sponge is not just a barrier method in the form of a sponge, but at the same time, it also contains a spermicide, non-oxynol 9, 1000 milligram. This is associated with a potential life-threatening complication of toxic shock syndrome. Non-conventional, should be inserted 4 hours prior to intercourse, should not be removed for 4 hours later. Then this is combined oral contraceptive pill Mala N. In Indian program, there are 2 contraceptive pills, Mala and Mala D. Mala N is totally free of cost. Mala D is given at a highly subsidized cost of rupees 3 per packet cycle. When we look at content composition, first 21 pills are ethinyl estradiol estrogen and levonorgestrel as progesterone. So, ethinyl estradiol is 30 microgram, levonorgestrel is 150 microgram. I can say 0.03 milligram, 0.15 milligram per pill. Last 7 pills in this comprise of iron tablets. This is 60 milligram ferrous fumarate, allows withdrawal building, maintains continuity of the cycle, and also prevents or reduces the anemia in the woman. Now, this image shows clearly what I was telling you. Last 7 pills are 60 milligram ferrous fumarate. These are different types of IUDs. What we should definitely know is that Lippi's loop is oldest IUD, IUD with highest failure rate also. It is generation 1 IUD. Generation 2 IUD includes IUDs like copper T380A in the program, which is having a highest shelf life of 10 years. Indian RCH program recently introduced second IUD, again from second generation IUD, medicated IUD, copper IUD in the program, that is copper T375 multi-load. Copper T375 multi-load is also there in Indian program now. Its shelf life has been found to be 5 years in the program. This is diaphragm, a contraceptive recommended traditionally, technically for educated women for temporary contraception. Reasons are many. Reusable contraceptive, non-conventional, should be inserted 6 hours prior to intercourse, should not be removed for 6 hours later. Use along with spermicide. If not properly used, it may lead to toxic shock syndrome like vaginal sponge. So diaphragm is not a popular contraceptive in our country. This is Antra. Antra is actually rebranding of the older DMPA contraceptive. Which category of contraceptives DMPA belong to? This is a depot formulation, injectable hormonal contraceptive given in a dose of 150 milligram intramuscular injection once every 3 months. Now, this contraceptive is associated with a side effect of irregularization of menstrual cycles. Net N 200 milligram IM every 2 months, norethistérone enanthate is another depot formulation. This is Chaya. Again, rebranding of the older contraceptive Saheli, Centroman. But actual chemical which is there in Chaya or which was there in the older contraceptive Saheli, that is ormeloxifene. Ormeloxifene is actually a selective estrogen receptor modifier. So, unique feature of Chaya Saheli Centroman, India's only non-steroidal OCP. No estrogen, no progesterone. Also, it is once a week pill. For first 3 months, it is given twice a week, then once a weekly pill. Its Pearl index is high, 1.84 to 2.84 per 100 women years, developed by CDRI Lucknow. This Chaya contraceptive or Saheli contraceptive is contraindicated in polycystic ovarian disease. Nischay. Actually, Nischay is not a contraceptive. So, what is Nischay? Under RMNCH plus A strategy of RCH program, this is a type of, yes, home-based pregnancy testing kit. UPT, urine pregnancy test it is. Friends, you are so close to victory now. Don't you dare give up now. You are so close to the final result, the final goal, the ultimate aim you are having when you started preparation. This is the time to put your vehicle in the final gear. Utilize the time maximally now. Do not waste any shred of time now. This is the time to deliver the final knockout punch, right? So stay on course. Preventive obstetrics, pediatrics, geriatrics, we are looking at the RCH program of India, Reproductive and Child Health Program of India, 1997. If you remember, earlier we used to have JSY, Janani Suraksha Yojana, because at that time focus was on obstetric, that is mother's care. But then we realized mother is not alone. Her health is intertwined related with newborn also. So we made it obstetric and newborn care in our country. So older Janani Suraksha Yojana now became JSSK, Janani Shishu Suraksha Karikram, having two components, Janani mother, Shishu newborn. Now this obstetric care is of two major types in our country. One is essential OBS newborn care. Second is emergency OBS and newborn care. Emergency OBS and newborn care is of further two types, BMONC, CMONC. BMONC is basic emergency obstetric newborn care. CMONC is comprehensive emergency obstetric newborn care. Now, at which levels these operate on and what are their components? Let's look at that. Essential OBS and newborn care, which can be given by any MBBS medical officer, is for MCH level 1, that is primary health centers. MCH level 2, here BMONC care is given, 24/7 PHCs and CHC. MCH level 3, maternal and child healthcare level 3, FRU district hospital CMONC care is given because emergency care needs a specialist MD gynae-obs or a MD pediatrics. When we look at essential OBS and newborn care, there are 5 components. A pregnant female comes to your health center for the first time, registration of pregnancy, then give her antenatal care, then make sure she has a safe delivery, then provide her with after delivery post-natal care, and side by side remember newborn care is also an important component now. So these 5 components make up for essential OBS and newborn care. When we look at BMONC care, this includes manual removal of placenta, oxytocics, antibiotics, anticonvulsants, assisted delivery,